Oh, hi. I have to make it quick. I kind of told Eugene and Richard what I would like to be discussed just because one of my patients isn't doing well. He might not make it today. So I kind of have to be there. Um, so basically, we finished we're like sorting out everything. We're gonna finish writing the first draft today, slash tomorrow. I think everyone did their part. We just need to like mesh it all together. And then we're just gonna edit the whole thing by ourselves first because the flow is a little bit weird. There's just a lot of information. So we need to cut out everything as much as we can. So we're gonna trim it up this week between our authors, and then we're gonna show like the finalized version to you next Tuesday, so that you could maybe go through. But before that, well, Eugene did the meta-analysis part, but like there was just so much information that came out of it, and not just that part, but also from like the narrative side too. So I'm just not sure like how we can focus the information just because like if we have to say everything, it's gonna take too many pages. So
Mm,
if we can discuss that, that would be amazing. But I think it might be best after to be discussed after you hear Eugene's part of the meta-analysis.
sound good. And what journal are we sending it to?
For now, it's just Lancet, and then once they reject, then we'll move on.
Well, dream big, dream big. Lancet.
Yeah,
I
for
mean,
now.
they said they are interested in the topic, right?
Yeah, and then they told me to make sure I include the fact that we discussed this in the email when
Yeah,
I send it in so that it doesn't get filtered out.
right, right.
So we'll see how that goes.
Yeah.
But yeah,
Um,
I'll pass it to Eugene. I'll try to stay as much as I can, but I might have to run out soon. Yeah, sorry about
sounds
that.
good. That's okay. Okay, Eugene, show us the meta-analysis.
Okay. So where's the, they're not much different from the one that I showed you guys last week, but I just reorganized a few results into like grouping it into a different section to make it more succinct and simple and clear. So I'll just update you that. So for meta, I decided to make a figure 3, figure 2, including the overall sensitivity and pooled specificity and pooled diagnostic odds ratio. Just that there will be, as of now, I'll just put 3 figure into one figure, 3 like graphs into one figure titled like this: forest plot of included studies, sensitivity, specificity, and DOR. And for the figure 3, I try to come up with the receiving our operating curve. And the tricky part is the one, the first software that I used. They showed us each point where each point of the studies here. But the thing is, they didn't show us the like summary point, which is most important in terms of this graph. And the other
What is summary point?
summary point is kind of a best, like the optimal point based on the studies. So in the previous graph, I showed you, maybe just give me a sec. I'll just, so this is made by Rivman software, Review Manager, which is made by Cochrane Group. But R, when I try to draw SRC curve with using R, there's an issue that the x-axis is expressed as false positive rate rather than specificity. Here, it shows us the specificity, but I remember, Dr. Che, you want me to change the x-axis into the specificity, but I found out that there's no way for me to do that with using R. And I found so many other articles just reporting that way, just false positive, leaving this x-axis as a false positive rate. So I'm wondering which graph that I have to choose in the end, between this and then the one made by R. And for the subgroup analysis, you remember I showed bunch of graphs depending on the stage and types, cancer types, but I ended up just expressing that in just one table like this. So I did subgroup analysis with a few variables, methodologic. I just kind of get this idea from another meta-analysis on diagnostic accuracy test, and I try to classify the studies into case control and cohort, to see whether there's a difference in terms of the results. And I found out that in terms of methodologic and gender classification, there was, interestingly, when I sort out the studies according to the gender of the population, specificity was a little bit different. And for stage, sensitivity definitely differed, as we expected. So I put stage classification in two different ways. Like I try to do subgroup analysis with a stage 1 and 2 and 3 and 4. And I try to classify them into more detail, stage 1 and 2, 3, 4. It shows us that clearly sensitivities increase as stage advanced, like you see here. And for cancer type, yes, breast was prominent in terms of low sensitivity, having low, like when you compare the range, the breast was like set apart from the other types. So maybe I can, we can confirm it with the chi-square, a subgroup differences test as well. So I would say maybe I can just post this table rather than posting all the bunch of different figures and forest plot for each different subgroups as of now.
So for the stage 1 and 2, why is specificity 0?
Specificity is 0. Oh, this is not specificity. It's about the heterogeneity value.
So heterogeneity is 0. What does
Yeah,
that mean?
heterogeneity is 0, which means specificity is not that different between the stages.
Between the stages.
Yes, if you see the result here.
So let's go up.
Go up to the figure.
So here, let's say, no. Go to case control. Right there. So between heterogeneity score for specificity is 97. It means that between those two, there's a big difference
Right.
in specificity.
Yes.
I mean, it looks like 96, 98, but that's a big difference, I guess. Okay.
Yeah, at least from the analysis part, it shows, yeah, it says it's different.
Male, female, big difference. But according to stage, there's 0 difference. I would just want to make sure it's true.
So honestly speaking, I think there's maybe some may pose a question regarding this data, and I can show the original data that I did this analysis. sorry, this is not. So for the stage, I think I can guess where it is coming from. So if you, so technically saying, the way that I did subgroup analysis between stage and the other like methodology or gender is quite different in terms of I just classify the, so I would say I use a total value, total like true positive, true negative, or false positive and false negative value for case control cohort or gender subgroup analysis. But for stage, I was able to extract the other data other than the total one, right? Because they report the different results per each stage. So to do the subgroup analysis in terms of stage, I had to put the same false, true negative and false negative values for specificity. And that gave us this kind of a homogeneous value for specificity, although there might be some slight difference. So honestly speaking, I'm not sure whether I can say this as a subgroup analysis, at least for the stage. Maybe I should call it as just another meta-analysis. Honestly speaking, I'm not sure whether I can include stage as a subgroup analysis or not. And it is same true for the lung cancer cancer type as well. Do you get what I'm saying right now? I can explain it more with the just showing you the data itself. So
Yeah, if you show me the data,
okay.
It is still subgroup because between different studies, you extracted just different stages.
That's why I put it as a subgroup as of now, but you know, the way that I did it is quite different between the stage and cancer type and the other variable like gender, or I'll show you soon. I should have prepared it earlier, but where was, I mean, yeah, it was interesting to realize there are quite a lot of ways to do subgroup analysis, like in terms of extracting data. I realized that by doing this at this here, if you look at the data that I collected, I try to find some like the overall result, and I quoted that as total. It includes all the subgroup, you know, subtypes
Numbers.
and numbers,
Yeah.
all the numbers. So I use this kind of a total value. Here you can find all the total value that I put for each study. I use the total value for subgroup analysis for gender and the study type. You know what I'm saying? But for the stage and the cancer type, I had to use each different like value like this for the stage and the cancer types subgroup analysis. And for the case control, I'm not sure whether you noticed it already or not, but false positive, true negative is same across the cancer type and then stage.
Why is it same?
Because there is like no matter what the cancer type and then the stage, the healthy control was same, right? The healthy control group was same, and I was not able to find each different, like they didn't report their specificity according to their cancer type. So this is the way I coded this, coded the results. And
So let's pick one that go up. Can you go up?
this is the,
So let's look at the Klein paper.
okay.
So total true positive, any cancer,
Mhm.
and then you have true false positive is 6. That's from
Yeah, I can,
healthy.
yeah, I'll go to the article itself.
It's blocking. Okay. True negative is the healthy population that came back negative. False negative is among cancer patients that came back negative. Now, if you go to thyroid cancer, you have 0, no thyroid cancer detected.
Right.
And the false positive is 6, true negative is 1, 2, 4, 8, false negative is 14. So there were 14 thyroid cancer patients that were not detected.
Mhm.
Okay. So this,
This is the claims paper, and I got the total number from here. The part
Okay.
A.
so you have to share that screen. It's all blank.
Oh, okay. I'm sorry. Okay. Let me share it again. Okay. I got the total number from here. And they report sensitivity per each cancer type. Here.
Yeah, so that thyroid was 0.
Yeah. This
But
is
it's
where
going
I
up.
got the data. Yeah.
I see. Yeah, so. Okay, so I guess this is sensitivity. Sensitivity changes a lot by cancer type. And where's the specificity? Is there
So
a
I
graph?
just no, there's no separate graph for specificity. They do have a like sensitivity according to the each like stage per each type, but I didn't use it. But
Okay.
other than that, like this is about the like origin prediction. This is not related to our paper right now.
Mhm.
They only
Yeah, this
do
one.
they only do have a sensitivity. Oh,
Okay, just
I'm sorry. Yeah. So I just
sensitivity.
assumed I just assumed the control for each different cancer type and stage as well, you know, to make it as like to make it sense. To make it
Okay.
make sense, yeah.
So look how they showed staging 1, 2, 3, 4, and 1, 2. Oh,
Yes.
1, 2, and 3, 4. So that's how you should put it in your table, in that order.
Oh,
And
okay. 1, 2, 3, 4, and 1, 2. Yeah, okay.
and if you have anybody with missing staging, then you could put as missing.
Yeah, there are 2 studies report like a missing. But I didn't do that because they were only 2, so I was not able to combine it.
Oh, okay, then that's fine.
Yeah. So may I go back to the original data
Yeah.
set?
So I know how you did it by disease group. So how is it different? You said there.
Oh, disease group? Okay, let me go. For
Disease
cancer type,
stage.
as stage, there was a striking difference according to the stage. And it was pretty exciting to see that. Let me share. So I didn't put the first plot according to the stage, but I can show you that it's a little. Just give me a sec. I'll Yeah, I have a data, but I didn't put it into the document. But because I'm not sure whether that's worthy to be there or not, but cancer. Oh, maybe I'll find it. But do you think it's like it makes sense? Does it make sense to do the meta-analysis like this? So I was even thinking like maybe should I do only make a forest plot only for the sensitivity, because for the specificity there will be no like difference in terms of stage or cancer type. So
It's okay to leave it, but I want to know why specificity changes so much by gender and
oh mm,
I think for those, like there were papers that only had like women and papers that only had men. So like they had different control groups that they got their specificities from.
that's
so
true. That's true.
so I guess staging difference by specificity. So this you have to write this in your
Okay.
discussion
Yeah, but
that the
yeah.
staging and disease group difference
Yeah,
I guess
will.
there was no
Yeah.
difference in specificity, mainly because they all use the same assay. But I guess in terms of gender difference, you are comparing different studies, so
Right,
different
right, right.
assays. So it's not really the gender difference. It is
Maybe.
more of an assay difference. Do you understand?
I would say, so if I just can share a little bit more about my thought, then you know, so what I did was I used total. It's different total value. Oh yeah. Maybe I think I'm getting what you're saying right now, but for the gender or study subtype, I use this kind of a total result for each study, right? So it means I'm comparing each study, right? But for the stage, I did compare each study, but at the same time for the stage, because I classify the results of one study into different stage and different cancer type, I would say I compare some results within the study, in addition to the like between the studies. So it may cause a little bit of confusion, for the readers, and I would make it clear in the paragraph, maybe in the method chart. So I really wish I could show you how I technically did the analysis right now. Hence, so here, I just want to show you the sensitivity difference between the cancer type. This is gender, stage. Let's run. Yes, if you see this, it will give us the results soon.
It's very blurry. I cannot read
Is it
anything.
okay? I'm sorry. Like, yeah, I just want to show you the plot.
I don't see any plot. I just see the Excel file.
Really? Yeah, if it's okay with you, I'll just show you like individually after this meeting, the graph itself. I'm not sure whether it's that important right now. So yeah. So you want to go back to the results of
Okay.
the manuscript?
No, let's finish this discussion because I think it's important.
Okay.
So the paper that's already been published by
Mhm.
different cohort studies,
Mhm.
it's important to show that by staging or by gender, that sensitivity may change
Mhm.
because, you know, breast is unique to female and that changes the gender. So I think it's important to discuss all this. Why is there a difference in sensitivity by gender? Maybe because of breast cancer. Why is there a difference in staging? Of course, advanced stage will be easily
Easier.
detected.
Yeah.
Why is there a difference between case control and cohort studies?
Yeah.
So
Honest. Yeah.
So specificity is really going to be similar. If you have it, you have it. Okay.
Mhm.
But again, the heterogeneity is really big, 97.
Right.
Maybe because it's different assay. Sensitivity is different because the cohort and case control, maybe the spectrum or the proportion of each stage, because staging is the major factor determining the spectrum of sensitivity, then, you know, case control and cohort study will have different mixture of or different proportion of staging between the two type of studies. So I think we should be able to explain why is it different. Now, I think it makes more sense to compare within study because you're not, the assay platform is not different. So within one study, how did staging affect sensitivity or specificity? I think if you decide to include, maybe it might be better to have within study heterogeneity for sensitivity specificity by staging or by disease group within, which probably is already calculated by the individual studies. So I think you have to
So Dr.
do
Che,
both.
yes.
Do both.
But I don't think I get it completely. So I already try to collect each different cancer type results across the study.
And did you add them up?
Yes, that's the result here. You show here. You see here. There are 5 studies, 5 studies that reported the long specific result, and I try to pull that up. That's how I come up with this number. So yeah, so this column, the right next to the variable column means how many studies are considered for that specific condition. Yeah, so for lung cancer, there are 5 studies which report the sensitivity of lung cancer specific, and colorectal there are 5, breast there are 4, ovarian 4, and the other cancer subtypes there are only 2, so I didn't pull up that. But yeah, I think I already did what you mentioned, but I'm not sure whether I can put this result here in the subgroup like table, or should I make it more like different format so that we can show it it includes some, it deals with a little bit of in between, like heterogeneity within the study.
Hmm. So I guess this is pooled sense. So I want you to say,
Yes, this is
well,
pooled.
this
result.
is pooling, right? This is pooling.
This all pooling, but yeah.
So yeah, maybe in the title or somewhere just say pooled sensitivity, pooled specificity, just to make sure. Um, I think pooling makes sense. I think a lot of people will be a little bit confused. Is it within a study and between the study? Because one might want to see, by study, by within one study, what is the sensitivity by staging? Let's just talk about staging. One might want to see within one study, how does the sensitivity and specificity change within one study?
Right, but I think that's reported already in the individual study. So you want me to like just summarize?
Yeah.
Oh, okay.
And then do pooling so that they can see. Do you understand?
Got it. So other than pooling, you want me to present the just individual study results in a table, like summarized in a table or?
Right, so go show me your pooling graph.
Pooling graph, this one?
Yeah, this one. See, this is total number, right?
Total number, right? Oh, okay.
So you can do same thing by staging. Stage 1, 2, 3, 4, 1, 2, 3, 4. That way we see, and then you can do that with sensitivity and specificity.
Right. Oh, with sensitivity and specificity.
It's different graphs.
Yes, I think I can do that.
So you can do that for staging. You can do that for disease group. So that's how people understand it, and it's more intuitive.
Yes. May I just ask? So, if you see this, can you see my screen?
Yeah, you can magnify.
Okay. What do you see as of now? The Excel, or do you see the PDF file that I just pulled up?
No.
No.
Any new screen you have to
Sorry.
share.
Yeah.
The
So
screen.
can you see right now?
Yeah.
So actually, this is the one that I come up with the table. This was the original graph that I received that I get from the R. So if you see this, I collected every different single studies regarding the stage. You can find about each specific state sensitivity in terms of stage for each different study right here. So you want me to put this into the manuscript, right?
Yes.
Yes. So I think it would be really interesting for everyone. So if you see this, there's a huge, like a clear trend. If you see the pulled up results for each stage, it moves towards, it increases, right? Yeah. So this is the one that I find very interesting in terms of.
Yeah, no, this is really good. This is what people learn.
Yes. So maybe we can say that to detect early stage cancer, we really need to come up with a better technology, or at least better algorithm to be more cautious about early stage cancer, because it shows us that it's really hard to pick up early stage cancer compared to the advanced one. But the thing is, in terms of sensitivities, it shows us clear this kind of direction or trend. But for the specificity, because I put the same number for the specificity because I couldn't find any different result.
Mhm.
So it's very different. So I might need to just post sensitivity rather than specificity, because I will show you the specificity results very
Uh-huh.
shortly. Unlike sensitivity, like there's a little very similar results in terms of specificity. So I'm not sure whether that will be worthy to be reported.
No,
So
I think you should generate pooled
Oh.
specificity, and you should put that graph in supplemental figures.
Okay, then I can just explain. I put the same number for specificity because of this reason, right?
Yeah,
Oh, okay. Yeah, I think that makes sense. For the specificity, there's nothing prominent.
they're all same.
They're all same, other than a little bit of maybe here. Yeah, this is the specificity.
I don't see anything.
Oh, I'm sorry. Yeah, sorry. Oh, right now, this is the pooled specificity depending on each different stage.
Mm.
And you might notice if you look this closely, then you can find the values are probably same across the stage, and the events and total numbers are same because of the issue that we discussed earlier.
So events and total. So this is true negative.
Right.
This
True
one.
negative among the healthy control.
Hmm. Okay. Yeah, I think you need it.
Okay.
You need this. Maybe I think it makes sense to put it in, not just in supplemental. I think staging is important. So
Okay.
I would say just the total graph, total and staging sensitivity, total and staging sensitivity.
Mhm. What about cancer type?
I think cancer type is also important. I think case control.
There was no
Um,
difference between methodology. There was no difference. There were no difference.
Cancer type by sensitivity. Yeah, needs to be in the main figure, but maybe case control. And study design, maybe, yeah, the sensitivity, the both.
Okay.
The set, yeah, should be main figure, and the specificities for those could be in supplemental.
Okay, got it. Yeah.
Mhm.
But you're okay with the table 3, right? As of now, the subgroup table. I don't need to separate them. Right?
What is table 3?
Table 3
Can you
was
show me?
okay. Yeah, yes. For table 3, I try to summarize all the subgroup results here, like this. This is kind of the value of pooled sensitivity and pooled specificity. Just that.
Yeah, I think this is fine.
Then, but then other than this, I need to show the reader the graph itself, the forest plot itself.
Yes.
Okay.
But like I said, for staging, do what the other paper did.
Right. The order I need to reorder.
Cancer
Yeah,
type.
reorder. Okay.
female or male, you don't,
So for female or male, it's a little bit tricky because there are only 3 paper that have
hmm.
only one gender. I don't think it does
So,
make sense.
so I don't know,
Mhm,
yeah, so having mixed there,
mhm.
I don't know if it makes sense. Version 1 and version 2.
So yeah, version 1, I try to separate them into female or male or study that dealing with both gender. But in that case, we only have 1 paper for male and 2 paper for female. So I try to combine them into just single gender like group. But specificity was different in any way, in any, depending on any like classification.
And why would that be?
Um, actually, I need to I need to come up with an explanation for this result, but yeah, if you look at the sensitivity, it and also the statistic tells us that sensitivity wise, there's no difference, but the specificity wise, I think there's just one thing. The study dealing with single gender specificities are a little bit less than the study dealing with both gender, and maybe
I think it has to do with the disease type, like prostate cancer and
oh
breast cancer. There may be difference in, false negative rate or something like that. So look into it, come up with the discussion point for this, because you need to explain this.
okay.
And my suggestion is just do the female and male. You don't have to put mixed or female or male. Just do
Oh.
female and male. That's it. Just show that difference. And putting mixed here is going to dilute things. Okay,
Oh yeah, yeah.
and
I
then
didn't know about
explain the difference in specificity. I think it has to do with prostate and breast.
although the number would be small for if we decide to include only like single gender, but that's fine.
That's fine.
Okay.
Okay, I'm gonna have to make some calls. I'll take a break and maybe I'll get, and then you guys take break and I'll be back in 10 to 15 minutes, okay?
Okay. Yeah, sorry for taking up so much time. Yeah, we'll be back again
Okay.
soon.
It's from any of your analysis?
Not much. The one that I do with the MRD project, I already discussed with you. So you told me it's not available because of the sample size. I cannot calculate the hazard ratio, but I just write about that in the method, and you wanna have a look at the manuscript that I sent to the Signatera people, or are you just okay?
No,
I'll
I'm
just-
okay.
Okay,
Okay.
okay. Okay, then.
What about the cancer incidence?
Oh,
paper?
for cancer incidence. Thanks to the Suwon and Sebin, they collected the data very well. And I'm thinking of doing the meta on that topic within this week so that I can show you the results by next week.
Okay,
We are almost there. We ended up having five articles on multiple cancer
mhm.
and 3 or 4 articles on single cancer. So not that much information, but yeah, I think still it's doable. So yeah, I'll update you with the results by next week. Yeah.
Okay, so cancer instance by transfusion. And then there's a review paper with you and Seokju. What happened to that one?
Right. But you gave us comment that it's better for us to separate the cancer incidence and survival part.
Uh-huh, yeah.
So for that narrative review, we're dealing with only with the like cancer survival or the impact of transfusion on cancer survival, right?
Right.
Or mortality. But that was not meta or systematic review. That was just a narrative review. We didn't
Yeah.
even like, yeah. So we have a nice table and already written manuscript. So you
So
want
what's the holdup?
just nothing much, but we honestly have not received your feedback on like every detail thing. We haven't show it to you like officially in the lab meeting, so that's the like kind of hold up thing. If you're okay, we can just proceed it with move it forward to the submission process because Seokju,
Yeah.
yeah.
So I want to make sure what's ready, there's no delay.
Okay. But the
So
one,
I think you need to tease out the incidents and survival and make it into a separate,
yeah, we did that. We
and-
separated all the things. We separated.
yeah,
everything.
and then reformat that.
But the thing is, it started this project, this narrative review started more than 2 years ago.
Uh-huh.
So one tricky part that I discussed with Dr. Cho was that do we need to update our narrative review in terms of getting more the latest information or not?
Yeah, that's always a challenge if we
Right.
don't send. I mean, the answer is yes. We have to update
Obviously,
what's
yes. Obviously,
obvious.
yes.
That's very obvious. Remember, we were 6 months different. I guess 1 year delay with radiomics. We had to review more than 100 papers. Remember
see.
that? Yeah.
I've heard about that. Yeah. I was
Yeah.
not there, but yeah. But the thing is, we haven't actually, even for the 2 year, even before 2 years ago, like, I mean, even 2 years ago, we didn't like look it up very thoroughly. We were a little bit selective on selection of article. So we'll see. Okay, I'll just come up with the best, maybe efficient way, most efficient way to update our search. And then,
So that's not our priority, but so think about this way. So if you make it systematic review, it's going to take a lot of time.
right,
So I want that to remain as more narrative review.
of course. Yeah.
And then I don't want to miss key articles that came out within the last 2 years.
Mhm.
So the goal is take out the incidents, update
We did
key
that.
articles,
Mhm.
and just reformat to whatever paper we're aiming for.
Mhm.
Do you know what journal we discussed?
I think, yeah, Dr. Cho mentioned Annals of Internal Medicine, something like that.
Okay, that's pretty high impact.
Mm.
But yeah, you can start there.
Okay.
And the abstract, at least you can send it now to gauge their interest. And reformatting and updating the recent information.
Right.
Any of you, Richard, Dean, Arnie, you guys can volunteer, participate for this project. Low hanging fruit. But I don't think you should work on it, Eugene. I think you need to find a student or another researcher, take on take it to
Okay.
submission phase, because there's too many. But make sure this is
The one that I should not miss. Okay.
yeah.
Take care. Okay. Okay, I'll take care of the cancer incidence and survival meta review from now on. Yeah. I'll
Okay.
just- yeah.
Hey, is Nimartha in the lab or is she gone?
Oh, she's gone.
Okay.
Because yeah.
Okay, what else? Okay, and then the
Okay.
incident, you're gonna show it to us next week.
Next week, yeah.
Okay. And so Singmi's papers are almost written up,
Yeah,
except for the
almost
graph?
written up. Yeah, yeah, almost written up, and
Okay.
it is sent to the Signatera people so that we can receive
Okay.
their opinion, yeah.
Okay. Okay, anything else?
Yeah.
No?
That is,
Okay.
not as of now, yeah. I'm done,
Okay.
yeah.
All right, Grace. Any update?
Hello. So as I sent you the poster, I ended up submitting it. I also changed the presenting author. So that's all taken care of. For
Mhm.
the email address, I just ended up putting my own, but otherwise, like the presentation itself can be done by someone else. And for the Dr. Zuni interview video for the Pacemakers project,
Yeah.
it took so long. I ended up uploading it to YouTube as an unlisted video.
Uh-huh.
I can send you the link privately if it would take too long to watch right now. I
Yeah,
asked,
just send it to me, the link, and I will watch and approve or give you comment. Then you can reformat it and upload. Yeah.
okay, I sent Shauna some screenshots to make some thumbnails. So once I get that and once I get your approval, I will post it. But the thing is, for the title, I didn't know what to title it because everyone had like a meet oncologist Dr. Che or like meet
Ah,
transplant survivor Albert Curie, something like that. I ended up putting, because in her introduction, she said she will be a chief resident. So I put.
I think she is now a chief resident. So meet the chief resident or something like this.
Okay.
Chief resident. Yeah.
So I said meet chief resident, Dr. Zanera Shah. So I think that's
Right.
okay. Okay, so I'll ask Shauna to make a thumbnail with that kind of title. So that's that. I talked to Eileen and Lena about the variant classification project. I made a checklist of everything we have to do.
Mhm.
They said they'd be willing to help, so that's all good.
Mhm.
I'm just running into some trouble because I forgot how I did some things. So it's becoming inconsistent with what I did for the abstract. So I'm trying to
Uh-huh.
backtrack and see what I'm doing wrong right now or what I did wrong
Uh-huh.
before. But once that gets going and I figure it out, it shouldn't be too bad. And Eileen also said she'll help me write up the draft, which is great because she worked with Emma for the previous manuscript. So that
Mhm.
shouldn't be too bad. And then Dr. Liam and I also talked about restarting the pacemakers manuscript thing and getting that going.
Mhm.
My goal is to have most of that done by August or I guess continuing on, but like to wrap up those projects before. Yeah.
Yes. And you're gonna write it as a one paper, right? So it was
Yeah.
too abstract. Yeah.
Yeah.
Good. Good. Yeah. I mean, like you both of you work together to write it up, and ideally you'll be the equal contributor. But if formatting, writing, discussion, if any for any aspect, if any one of you want to help out, feel free to reach out to Grace or Liam and be part of this team. Good. Okay. And I guess oh yeah, Richard, how is your AOSC program going? Like, are you in that program, or what do you guys do? Yeah.
Oh yeah. So I'm actually doing that with like a different project.
Oh, okay.
Yeah. But yeah, it's going. Yeah.
Okay.
Yeah.
Yeah. So I was gonna say you can do that with different mentors. I think Stas did it. Stas and what's her name? Samantha. Yeah. She did it with our lab, and Stas had a medical student like a Feinberg
Mhm.
interview or something.
Yeah. Yeah, no,
Yeah.
cool. Yeah, the thing is like I had to like pick it by like February and like you didn't like I emailed you a few times actually, but you replied a bit after I had like the deadline to like select it. So
I see, I see.
yeah, yeah.
Yeah. So that's that opportunity you have, Grace, when you start. So Richard Grace is going to be the incoming
Oh, yeah. Congrats.
freshman, yeah, for the
Welcome, welcome.
medical school, yeah. So what I'm saying is you could be in the like a formal program, and they support you for your travel, for presentation and things like that.
Mhm.
But there are other funds, like the meeting has their own funds for supporting students. So remember that. Okay, anything else, Grace? Okay,
No,
good,
that
good.
was-
Yeah, keep us updated on your progress. Okay, Arnie, do you have any update?
So basically, our project, I don't know, yeah, it's kind of be like really in the slow progress. Like it's almost like done, but because we want to add the mortality and everything, the data collection is maybe right now it's only like about 30% or like 35%. I need still to come to the lab also to do like collecting the data little by little. But our target is before because the submission from the CC is in the 28th July is the like the last day. So we still have time for the abstract. So it's like my target in 20 July, like we're finishing collecting all the data before 20 July and like analyze it and do it like an abstract and like before 28. Because like it's just like kind of hard for like submitting for like collecting right now. And also I think like right now, so Eugene and Liam and also Zuni like kind of to help collecting the data. I think that's all the progress that I can share for my project. But I will make sure that it will finish to submit in CC.
Okay, Junie, do you have anything to add?
So, Dr. Che, I will request you the password for remote access again so that I can do data extraction.
Yes, so call me or text me. I will send it to you real time.
Thank you so much.
No problem. And so what is expected, when are you going to be done with all the analysis?
So my target is like in 20, we finish all the extracting the data. Analyzing is like about takes like 1 until 2 days, like 2 days, we put it. And after that, like giving the abstracts. Actually, it's kind of a bummer because like it's like the latest submission is 28 and my exam in 29. So at that kind of week, I will put like I will give like the writing the abstract. I think I will give it to the rest of the other persons. I just like helping until extracting the data in the way that I can do until 20 July. Liam
Okay.
also, yeah.
So Junie, you're in charge because Arnie is going to be busy with the exam. So make
Yes,
sure.
I can
Yeah,
help in writing.
yeah. Okay, so yeah, make sure you don't forget the deadline, and we should be able to submit. So finish all the writing, discussion, results, and just when you have the result, just plug in the numbers. I mean, I think we know the trend.
Yeah, I feel like after my exam, we can start to do the original paper one. Until 28 is only the abstract, but after I finish my exam, I back and we can try to do the finalized things.
Sounds good. Okay, thank you.
Thank you.
Richard, do you have any updates on what you've been doing?
Muted, sorry. Yeah, I have a couple. It might take a while. Like, does anyone have to like leave first, I guess?
No. It looks like.
Okay, cool. Okay, I will Sure. I had some questions about the like the manuscript for the cancer review screening.
Yeah, yeah.
Cancer screening review. Let me share this really quickly. So the first question I had is about the results where we kind of like summarize each article and talk about it, because right now, like the narrative part that we wrote is like 1,700 words and the total is like 3,500.
Mhm.
So it's like a little bit long. And I was kind of wondering like what you thought might be like like a way that we could like cut down or revise it. So basically what we like how we structure the paragraphs is we have like,
Can
And-
you magnify a little bit?
oh
It's
yeah.
kind of small.
So the way we
Yeah.
structured it is we have
Mhm.
like an introduction sentence where we're like, okay, like how does it work? Like host
Mhm.
consumer, what the test measures.
Mhm.
And then we talk about the articles, like which articles. And then like exactly like how the assay works, like a little bit more technical in terms of
Mhm.
how it
Mhm.
works. And then we talk about the results. So first we talk about like how many patients were used, and then the like statistical part of it, like sensitivity, specificity, we do
Uh-huh.
for each article. And then like one more sentence about like key findings, like for here, they were able to detect the like origin of the cancer from the blood test with like
Mhm.
blah 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 accuracy. Or we'll
Right.
have like other key findings that they might have.
Mhm.
But the thing is like there's like 15 studies, and when we do this for all of them, it becomes kind of lengthy. So I wanted to hear like your thoughts about like, is it structured okay? Like how could we change it? That kind of thing.
I see. I see. So the question is, are 15 studies of similar weight? Like, are they equally important? Or I think I guess the larger the sample size, the more weight it has. And I think you'll have probably like 4 or 5 key studies that's worth one like whole paragraph to describe it. But the rest of it, I think you can lump them up, and the rest of the studies were these, looking at kind of summarize the rest of it into 1, 2 paragraph. That's what I would do.
Okay. So studies with like larger populations and I guess like better sensitivities and specificities should be prioritized, do you think?
Yeah, send the ones that are used to generate the pooling graphs.
Oh, okay.
Yeah, I would do that. And for the key studies, this structure is fine.
Okay. Okay.
And since you mentioned tissue of origin, I'll go back to Eugene. Would it be possible to look at the accuracy of prediction, TOO, like a between studies?
So far, I definitely have to look at it again, but my impression is there would not be much study that for the data is available. Only 2 or 3 maximum, I think they looked at the tissue of origin
So
accuracy.
even if it's 2, I think you can pull.
Really?
Yeah.
I thought minimum would be the 3. But
Okay, use 3. If it's 3, then you can pull.
okay, we'll take a look at it and figure it out. Yeah.
Yeah.
Okay. And then I wanted to ask about well, actually, this is Juhi's question.
Uh-huh.
It was about the structure of the discussion.
Yeah.
She has in, I think, this file. So she wanted to see if like we covered everything, because right now like there's like a few things missing. We like had like a checklist that I can kind of show you where like
Mhm.
for like systematic reviews, and we're missing a few things from the discussion. So basically, like, these are the paragraphs. It's kind of like a lot to read.
Can you magnify it? I can't.
Yeah,
It's
sorry.
yeah. So what is the question?
Just like, is like the order of the paragraphs okay? Like, do you think that everything that we're including is good, essentially, for the outline? Because they're written, but just looking at it.
Oh, okay. So this is the first review. And then right, it's comprehensive multi-cancer. Yeah, it's timely. Okay, that's fine. You know, different studies, what's similar, what's different is overall. And what are the technologies? I guess well, the cost effectiveness, you don't have to mention like the actual cost. It's, you know, it's just the general principle. Like you don't have to do, you know, lung cancer screening panel, then do, you know, breast cancer screening panel, then do colorectal, you know, screening panel. This is like multi at one blood draw, you know. I mean,
Mhm.
it's just right that it's like, you know, the multi screening makes sense in that regard. That's what I mean. You don't have to quote how much each test is. That's what I mean.
Okay.
And then just say there are, you know, high risk studies, but meaning, you know, you can have a study designed to only screen, you know, current or heavy HEPAS smokers. That's kind of high risk group, right? But in this review, that's not our. We want to so. I guess we should make that point clear that there are definitely studies focusing on high risk group and give them examples. But then the focus of the study is to see if this multi-cancer multi-omics blood assay is it applicable in general population. That's in high risk group studies are ongoing, but you know, it is a valid strategy. It is a low hanging fruit, and it is definitely definitely the probably easier accessible way to deliver such screening with higher yield, of course. So we're gonna kind of endorse, and that's really important pathway. But also say the focus of our review is you know, it's really general population focused. So I don't want the reviewers think, why didn't you guys, you know, review all the smoker and, you know, like why did you miss those key papers? I don't want them to criticize us. I want to like give them our full disclosure that this is our focus. That's why we reviewed only those papers. So talk about two different strategy: high risk strategy and general population, and you know, then just say our focus is just this. And then technology, ctDNA, proteomics. It's good. Yeah, and then just say most papers used you know, ctDNA for sure, or you know, what it's a single technology base or it's a combined technology, and if it's combined, what are those? You know, try to show that in pie chart or something. And then trial, you know, case control, cohort studies. Yeah, and then the study landscape. So people always want to know what are the ongoing studies that did not produce any result yet. So we're telling them, hey, look out for these study future results.
Mhm.
Yeah, so that's good.
Okay. And then paragraph 5 was like, how do we interpret information and stuff?
Age, staging. Yeah. Staging is important. I don't think it's so yeah. That's good. Go to paragraph 6. Yes. This is all good discussion. So here, do not try to give answer. This is just throwing questions like, these questions are important to address. And you can give example like, 23andMe is the example. Who owns the data? Who, as a society, are we willing to reimburse fund or and then is so the B2C directly to customer, that's patient, but this is not patient, this is general population, this is healthy people, this is preventative service. So do you really have to go to see doctor to get it ordered? In 23andMe world, no, because I want to know my genealogy. Like, why should I see doctor, right? But then they also give report about, well, your chance of having diabetes is this. So why would cancer have to be different? Your chance of having cancer, just like diabetes, is this. So are these companies trying to sell it directly to general population versus, and as a society, what is the right way? So we need to have this discussion, dialogue.
Okay.
But what has happened to the 23andMe business sort of will give us a clue what's likely to happen in the future. So it's more about like, let's think about these elements as we as society uptakes this general population screening strategy. And the future directions. Yeah.
Okay. Sounds good. And then so we also were using this it's like a checklist that is on, I think, JAMA. They have like a diagnostic test accuracy
Yeah.
or analysis, sorry, like checklist.
Yeah.
Like we've been using it to kind of make sure that we have everything required for our review. Do you think that like this is good? Because they have some things that like we didn't talk about and that I was not sure if like we should necessarily include, but
What are those?
like one of them is like talking about like, I guess like funding for these studies that we're analyzing.
Mhm.
Like how would we talk about like in the results versus the discussion part, like how it might bias the results that we're analyzing.
Mm.
Like here, this part.
Yeah, the funding source. Yeah, I think
Yeah.
that should be part of this discussion. Like these were all private company funded studies.
Mm-hmm.
Is there any NCI? Like, is there any like NIH funded study?
Eugene's shaking her head, so I think no.
Okay, so that's a really good, observation. Like, there's no, it's not funded through non, I guess it's all private sector And you can actually cite my paper. So I did a review and meta-analysis on how COI affects trial results. I was one of the co-authors on this paper. I think the main author was Sekwon, 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 first name, last name Jang, Jang, Sekwon Jang. It was a conflict of interest, how that affected trial results or something. Like, I don't remember the exact title, but you can search it in the PubMed and cite that, and sort of like, there is that bias. Just mention it,
Okay.
and then mention the fact there's no NIH funded study or something.
Okay, sounds good. And then another question was in the methods, they ask us to present the full search strategy for every like electronic database that we searched. So should we make a supplementary table with that? Like,
Yes,
okay,
table or diagram, like the flow. This is our search. Next, we filtered this, all that. Yeah.
okay, for each like database that we search. And then I had one more question that I do not remember. I might ask you later because I'm blanking on it.
Okay.
Oh wait, is there like a review protocol?
What is accessed web address? Provide trial registration number. Protocol and registration. Where the review protocol. Review protocol.
What I've known is like there is a Prospero site where we can register the meta-analysis or systemic review in advance. Maybe that kind of thing.
Yeah, I mean, we don't have to do that in advance, so I think we can
Right.
ignore this.
Right.
We can, there are trial numbers, right? Some trials are registered at clinicaltrials.gov. So you can say some of the trials have that number, right, Eugene?
Yes, I think we can check on that. Yeah. Maybe.
Yeah, just say we provided the clinical trials number. It's in clinicaltrials.gov.
Okay.
Okay. And then so like that's all I really had for the systematic review.
Okay.
There's also the introduction for the
Mhm.
like phase 1 trial.
Mm-hmm.
I can show you now, or I can like show you later. Would
No, show it to me now. It's okay.
okay. So let's see, share to-
So Dean, Richard is working on very similar paper, and this is for adenoid cystic. Is this adenoid cystic? Yeah.
yeah. Is like an introduction that I wrote. Liam helped to like edit some parts.
It's blank. I'm not seeing anything.
Oh, huh. Is that okay?
Yeah,
Okay.
just magnify it. Okay. So adenoid cystic, despite the persistence, it has indolent. Many experimental therapies thus far have undergone trials to attempt to exploit mutations. So a lot of it's just rephrasing from the other review papers.
Yeah, like it's I would say so. Yeah, kind of like summarizing like different like treatments so far.
Mhm. So the last paragraph, the furthermore,
Yeah.
dramatic tumor regression,
Yeah,
where
there
is
were only
that coming from?
so there were two patients. It was like 32 total. Two patients had a positive response, and it was like minus 70% and minus like I think they're both like minus 70%. I don't remember the exact numbers, but they wrote in the conclusion that it was a dramatic tumor regression. So
And what paper is this?
it was a 2019, it was like an abstract actually at ASCO where they like showed a phase 2 trial.
Is this our paper?
Oh no, this one at the very end is like an earlier trial with Nivo Ipi.
Can you show me?
Yeah, let me see if it's
And this is salivary gland. So
um
you-
not this one. Oh,
I think your reference number is 11 for this.
yeah. This one.
Can I see the last author, where it came from? Alan Ho. Okay, let's go down. So this is all AACC. Okay.
Mhm.
They had response rate of what was it? One confirmed PR,
In the first
one
stage.
unconfirmed. And then there was one more PR, two
Yeah,
two
two
confirmed
total.
PR.
Yeah.
Okay. Uh, you should cite our abstract as well. So I have a salivary gland abstract. I think it was AACR.
Mm-hmm.
Maybe one or like 2 years ago, something like that. AACR or 3 years ago.
Okay.
The last author's me or first author's me. And it's a salivary gland cohort, but within that cohort, we had half of them were adenoid cystic, and among them, I think we had either one PR or all stable disease or something.
Mm-hmm.
So you can describe our experience. So let's say our group looked at such and reported such.
Okay.
For the ACC cohort within the salivary cohort of this is just trial called DART, D-A-R-T, dual anti-CTLA-4 PD-1 therapy for rare tumors.
The
So yeah,
okay.
and then this ASCO, this year's ASCO in Chicago,
Mm-hmm.
Rivaserib. There's a phase 2 study result that showed response rate of about 20%, and that is currently under FDA review right now as we speak.
What was the drug called again?
Rivaserib. You're right, adenoid cystic phase 2. First author is Hyun-Suk Kang, Kang. The drug is called Rivoceranib, Rivoceranib.
Serenade. Okay.
Rivoceranib. So there's a phase 2 study published at JCO. Right now, abstract form, like the response rate. Oh, this is 10%. For this one. So discuss this result as well.
Okay.
But that's with other TKIs, but immunotherapy. And then I don't know if you started reading the immune landscape of ACC. You know, is there so my hypothesis, most ACCs do not respond to immunotherapy, and once that responds to, they might have more immune cell infiltration, some different immune phenotype. So we can hypothesize that they are two different groups. One is immunogenic, one is non-immunogenic ACC. And that subgroup is the one that probably is responding. And right now we don't have way to know which group has which.
Okay.
But anyway, yeah, go back to the last paragraph of the introduction. So introduction has to oh yeah, so recurrent metastatic salivary gland carcinoma. So salivary gland adenoid cystic carcinoma. So you have to that these responses came from, because there are many different types of salivary gland.
Oh, yeah.
Say. And then the review is, you know, adenoid cystic, it can be from salivary gland, but it could come from breast, lung, anywhere. Okay, so it doesn't have to be, but you know, you could say adenoid cystic carcinoma of salivary gland. That's better term. Showed PR. Something. Yeah, I think this is okay. Just make sure there's no plagiarism, there's no copy paste, all rephrasing, and so this is fine.
Okay.
And it's not phase 1, phase 2.
Oh,
1B, 1B. Look at the protocol. I think it was 1B. So it's
Okay.
just like an expansion. We don't change the dose, right? So it's likely to be 1B.
Okay. I'll ask for the protocol. I don't have that.
Yeah. And Liam, I don't know who has it. Yeah, you should get this protocol. Eugene and Liam, just work with me to get this protocol. It would be best to maybe have Liam reach out to IRB and have this downloaded, because this trial has been ongoing, but they might not have it in notice. But if you can email IRB to download this protocol and give it to Richard, that would be great. because protocol has all the rationale and, statistical, all that. And Richard, has CRO, Cancer Research Office, have they reach out to you about this cohort's end result?
I haven't received anything.
Okay. So Eugene and Liam is probably CC'd in that email. So let's follow up on the results of this paper. So so maybe Liam can follow this up with Richard. So what you do is just reach out to the coordinator of the study or the IRB designated person of this study and say, I think I sent this email before. I do believe you guys are all CC'd. Just send the follow-up email saying, can you send us the initial results? Not just the response, survival, but also the toxicity data. And we should be able to work with that person in terms of making tables and graphs.
Okay.
Okay. Any questions?
Pretty straightforward.
Good, good. This is how you learn writing trial results. There's a lot of different
Yeah.
nuances.
Absolutely.
Yeah. Cool. Anything else, Richard?
Not for now. No.
Okay. Great, great. Dean,
Hi,
you have
Dr. Chen.
updates?
Yeah, so I put together for the case report, I know we had the comments from the manuscript itself, which I already reviewed. The only thing we want to review is kind of the figures. So I have now the CT scans and then an updated
Okay.
other stuff. So this one is the tumor response map, and I think your suggestion was to just have the arrows for treatment.
Yeah.
I sort of referenced something Dr. Eugene showed me, but not sure if there's like more details or formatting to make it more visually appealing.
Yeah. So I would want maybe day one or day, what like starting day and then how many months later, things like
Okay.
that, then actual dates, because
Okay,
it could serve as a patient identifier.
right, yeah, okay. And then, yeah, I think again, it's kind of showing, so the enasidenib is not actually started until after the third ctDNA assay. So
Hmm.
kind of just put it off to the side, but yeah, I can clarify the like start and end dates.
Oh. Okay, let me get this phone call.
Yeah.
So yeah, it's a bummer that after enasidenib, there's no more Guardant.
Yeah,
But I guess
so
I
what
think
Dr.
it's
Eugene was,
okay.
okay,
Yeah.
what Dr. Eugene was saying is
Uh,
that we can just
I-
have this as,
I don't know if this has to be figure one though. I think figure one can be the CT scan.
okay.
That makes
Yeah.
sense too.
Okay, yeah, because I think the way the manuscript is set up, a lot of what we talk about in the treatments
Sorry,
leading up to
my
enasidenib.
speaker's not working. Bear with me. Okay, now it's working.
Yeah, so I think because the way we describe kind of the lead up to the start of enasidenib is for these other treatments. So that's why we had it first, but we can definitely change that.
Mhm. Okay.
Yeah, but I can review this more with Dr. Eugene and come up with a better way to show the months.
Yeah, let's do that.
Okay.
Yeah. And then this is just a table accompanying it with but I can make the same changes.
But this is kind of same with the figure, right?
Yeah, these are
Same.
together.
Yeah. You can make that into like the same
One-
figure.
Yeah.
Yeah,
Yeah.
yeah. Okay.
And then, so there's two sets of CT scans.
Mm-hmm.
So this one is comparing the primary right upper lobe nodule, and that
Mm.
one is the one that increased by 2 millimeters. So I just have some notes around like the pericardial effusion increasing and stuff like that. I guess my only concern was that, so we have the measurements from the radiology notes, but
Uh-huh.
in order to get these figures, I had to go into the scans and like draw a measurement and take a screenshot of that because I guess I wasn't sure like how to access. So like for this one in white, that's the one that the radiologist directly marked. But this one in yellow, I couldn't find the marking, so I just drew one in myself, but as long as it lines up with the radiology notes. So would that be okay to use for the manuscript the way it is?
So what was the point of this graph picture?
So this one is just showing, so there's, I guess, two nodules that are like measurable for the purposes of the RECIST criteria. This was one that increased by 2 millimeters, but then the other one actually decreased. So we have figures pointing both of those out. And then this is before aniseridone was started and then afterwards. So basically our argument is that the nodules themselves don't change that much, but the things like pericardial effusion is increasing. And so, yeah, just to show that kind of the direct indications or the direct evidence for the differentiation syndrome.
So differentiation syndrome is the pleural effusion, pericardial effusion, which is not that evident. I mean, I can see so first of all, the both figures, the chest, the height of the lung and the width has to be same. Here it's not. You got bigger a lung on the other side, so it's hard to compare.
Right.
So
Okay.
you have to make it same size, number one. And number two, the focus of this case report is really the differentiation syndrome and not the change in the nodule size. So whether it got a little bit larger, a little bit smaller, it shouldn't be the focus of this figure.
Okay.
The focus is, maybe put like yellow arrows around the pleural effusion and
Okay.
pericardial effusion. And that there's more GGOs.
Okay.
The more GGOs also compatible with differentiation syndrome, correct?
I believe so. Yeah.
Yeah, here I think lung size, they look similar, but still I feel like right
Yeah.
side looks bigger.
Okay. Yeah.
So rather than focusing on the nodule change, focus on those. And where are the pleural effusion? I don't see it much.
Yeah, I can.
Maybe we have to put another image that's
Yeah.
showing.
Yeah, I can
Diffusion
come
better.
fill out and sort through more images.
Yeah, so Eugene, you can help. Yeah, select the
it.
part that shows best pericardial and pleural and GGO. Maybe you can have before and after 3 pairs or something like that.
Okay.
It's will update the images.
Yeah, so I mean, I'll plan to be at lab tomorrow, so I can get those images in the morning. Okay, yeah. So even though we kind of reference the two nodules as a reasoning for the RESIST criteria, we don't need to include any images of those specifically.
Right, because that's not the focus of our review.
Yeah.
You
Okay.
can show it, it's okay, but I think you should show the most representative figure for differentiation syndrome
Right. Yeah. Okay.
features.
So yeah, I can update those figures. And then I think as you said last week or last lab meeting, I'll plan to use those same figures in the e-poster thing for Dr. Boomi.
Yeah,
I'll
that's
just
fine.
put, yeah, so just all the CT scans and then the treatment timetable thing.
Yeah,
And then I think otherwise the contents of the manuscript we already reviewed last time. So I'll work with Dr. Eugen to just proofread that one more time, and then with the
Submit.
BMC login, we can submit. Yeah.
yeah.
Okay. So for Dr. Pedro's report, so I reached out to the stats team, and they actually sent the stats report pretty recently. So I have a meeting with him tomorrow morning in person.
Mhm.
So hopefully I can just sit down with him and review that, and then have a more clear timetable for finishing that manuscript.
Sounds good.
And then, yeah, Dr. Elena, I'm still emailing and trying to get in touch with, but yeah, I can just keep trying to reach out to her and finish that.
Yeah, just CC me.
Yeah.
She's not part of Northwestern anymore, so her Northwestern email is not working.
Yeah, I have her personal email too that I've been.
Yeah, so
Yeah.
yeah, and same thing. Ask the statistician if you need any new data,
Yeah.
work on that. And it's not just the response survival data, you need toxicity table as well.
Yeah,
Um,
I can double check that.
okay. Cool. So let's get it out.
Yeah.
I mean, it's already written, but it's just a lot of fine tuning. Okay, anything else, Dean?
No, I think
So
that's.
are you working on anything else other than this one?
No, just these three right now. I guess two are closer to submission, and Dr. Pedro
Okay.
is still a little ways away.
Okay. All right, and who is admin? Oh,
I
okay,
use both computers.
okay. Liam, do you have any updates?
Hi, I do. My voice is gone, so I'll try my best.
I'm sorry.
So just a couple questions before I move on to kind of my presentation.
Yeah,
Let's see. So regarding Richard's write-up, we did send an email to the statistician asking for who's going to be running the statistics.
yeah,
Just a follow-up email, so we'll see what they say.
yes. There should be a signed, yeah.
Okay, and then regarding the discussion part for the cancer screening, at the end, you know how, all the kind of discussion points that we wanted to propose.
Mhm.
Is it okay to have a lot of question marks in the discussion paragraph itself?
So it's not a question mark. It's more about throwing out,
The discussion points.
the issues of who owns the data, needs to be discussed. And then you put a reference for a paper that actually talked about that issue more in details. So we're to kind of, in order for these to happen, pre-discussion on these themes, should be considered or something like that. It's just bringing up the topic and bringing up examples or things like that. So, yeah.
Okay. All right, then allow me to share my screen.
Mhm.
So the biomarker study IRB has been approved, and we have been sending out budgets to the respective companies to inquire of their final kind of decision whether or not to stay involved. So so far we've just been sending like the divided by 5 number for the budget.
Okay.
Do you think we should tell them the total budget as well, or just the divided number is okay?
Divided numbers, okay, we don't have to disclose. So we don't even have to say it's divided by 5. We say, because multiple companies are, yeah, you know, we could significantly lower the cost or something, you know. I mean, we explain to them, but we don't have to tell them the details.
Okay. And
Oh,
then
and then IRB approval, did they approve 70cc then?
yeah,
They
they
didn't make
didn't
any
say anything.
suggestion.
No, they
Didn't
just
say
said it
any
was
suggestion. Okay. See,
Yeah,
that's great.
yeah, they said, yeah, so initially they said like this study does not require continuing review like a week before.
Mm-mm.
But then just yesterday they like gave us the official approval notice. So
Mhm.
I'm assuming everything's okay then.
Mhm. Okay.
Okay. And then, so this is
Oh,
just an
can
email.
you also find out if the original study, like the cohort A, was it ever registered through FDA? I'm not so clear on that. So usually for biomarker studies, we don't have to, but can you ask IRB, because IRB or CT or Cancer Research Office, that's CTO, just ask them if this was ever, and then you can search clinicaltrials.gov if this study ever pops up. If it pops up there, it's FDA registered or something. Well, maybe that's two different things. So ask them if this was ever registered through FDA, and ask them if this was ever registered through clinicaltrials.gov.
Okay.
Clinicaltrials.gov is kind of run by NIH, or I don't know if I don't think it's related to FDA. Yeah, so let's figure that out. Yeah, just because there was a question when it was, if it was ever if it has ever undergone FDA review.
Okay.
But I don't know the answer to that question. Okay, next.
Yeah, so the next is an email from Interven. They're asking about the cohort A samples.
Mhm.
Just wanted to know what to tell them.
Interven cohort A samples. Oh, you mean like how to get them?
And what to tell Interven, like how many we have, how much samples we have, and things like that.
I mean, we send them the sample and they analyze everything already. I don't know what the question is about.
So they're asking about additional pre-CPI treated samples.
Additional. I don't know what they are. I think we sent them everything we have.
Okay.
The additional pre-treated samples, not pre-treated, they're gonna be the cohort B of cohort B.
prospectively going to be collected.
Okay.
Yeah.
And then for the double lung transplant protocol,
So follow up with them because they analyzed our sample. We need to write it. Okay. So tell them we do want to publish our mutual project to show how, glycoproteomics can predict response, survival, and we are happy to collaborate with other institutions because I know they did look at other 2 additional cohorts, and tell them we're happy to write up the manuscript together. So ask them what, if they have any pre-planned strategy to publish what they showed us at the ASCO. So we need to get it out, and we want the first, our cohort finding, whether it's combined with other cohorts or as our own Northwestern data, tell them we really want to publish this at the CISI meeting this year, and tell them when the deadline is.
so SITC
Yeah,
for a full manuscript or just for an abstract?
abstract. And say, also we want to write the full manuscript ASAP.
Okay.
We're happy to collaborate. At least we want to publish our own experience. But if you want us to collaborate, we're happy to collaborate.
Sure.
Yeah, send that email, CC me and Eugene, and maybe Isa. Let's see where we are. We
Okay.
can't sit on the data. Gotta keep
Yeah.
presenting.
Okay, and then next is the double lung transplant protocol. It's been submitted for notice. I'm going to follow up to see if they've already sent it over to CRC. We'll see, but then the next step is to go through CRC and then IRB.
So what is DT review?
I'm not sure. I was going to ask you that. So this is what notice shows me right now. So we have a protocol name and it's been submitted, but then it says DT review's been submitted.
Can you, I can't magnify, I can't read it.
Yeah,
DT review submitted. On by Brooke.
and then I haven't heard anything from them since. So I was just going to send them a follow-up email to see what the status was.
Okay,
So
so
did-
here's the thing. So that communication came from Brooke Travis.
No, this just came from notice office.
Email her, CC me, and say, this is a transplant protocol, and we understand this will be reviewed by, so DT means disease team.
Yeah,
So this will be reviewed by disease team, but just say, but this will be housed in thoracic surgery department, and this will be, you will be, consenting people. You will be the main person working on this protocol, and say, we do not want to take up any of the thoracic disease team trial space. We would want this to be discussed at disease team meeting, but we don't necessarily want this to be housed in thoracic disease team. We will be able to do this mainly in the thoracic surgery department. To send an email, CC me. Let's see what they say. The worst thing that can happen is this is going to compete with all thoracic, like a lung cancer clinical trial, like a therapeutic trial, and they will not approve it because this is not therapeutic study. This is more like observational registry study. Because there's limited resource, they always prioritize studies, and yeah, so that's very important. I mean, everything cancer related has to be discussed, but it should not be housed in this team. So this is super important. And if Brooke has any, so you know how to find people in the, and then maybe after sending the email, just also, if you don't hear back within a day, 24 hours, just call her. There's always like the phone number, search directory, because this is a very important issue. Okay, next.
Next is an email from Sanofi.
Yeah. I talked to Eugene about this. You can skip this.
Okay.
Mhm.
Then did you cover this one by any chance?
Yeah, so I emailed back and you guys are CC'd. So this is the HLA paper, correct?
Yes.
It's written by Dongyup Lee. Eugene, no.
Yeah, as far as I remember, I believe so. 2 years ago, maybe.
Yeah. So work with Dongyup, and Isir probably knows where the data is. And work with them. And as long as the data is de-identified, like patient number 1, 2, 3, and all the outcomes, you can share the data. So just CC me on every communication, and I think it was just 13 patients or something. So work with Dongyup and Isir to have that data shared, because they have their own algorithm. Yeah.
Okay. And then, so I'm currently still in the process of getting the NM research access. So I have to do like a lot of in-house training stuff to get. One other thing is shipping and handling. So I'm gonna get the in-house training like next month. But I'm not sure. They're saying I have to get like international IATA training. We'll see if the in-house training will suffice. If not, we may have to skip this one. But I can tell you.
Yeah. So what does it mean by handling? Because I think the phlebotomist will get the blood drawn, and your job is to just get them to the PathCore, or just ship it in a box and send it to the company directly.
Yes, apparently even for that, there requires some kind of like certification.
Interesting.
So I don't know how like necessary and strict it is. Because I would imagine I should be just able to just get it from the phlebotomist and ship it, for example.
Yeah.
But yeah, just like legally speaking, I don't know how much importance that has. But yeah, I'll keep you posted.
Mhm, okay.
Again, this is the Oncocyte MTA. They were asking some information from you.
Oncocyte. What is the information?
I don't know. It says they requested information to you directly, so I'm not aware of what the
Okay.
information is.
Eugene, let's work on this tomorrow when I'm in the office. Let's figure this out and fill this out together.
Okay, I'll let you know.
Okay.
Okay, and then the final thing for now is just regarding pacemakers.
Oh yeah. Not Terra. Are you going to find the discordant cases?
Yeah, so we have to work on that. We just didn't have the time to go through all the patients yet, but we're working on it.
Yeah. So I texted you one more case yesterday.
Yeah.
Yeah. So as long as we have just a few, and then I told you how to work from home through Epic. So just text me. I'll send you the time the passcode real time. The passcode changes every 10 seconds or something.
Sure.
Okay.
And then pacemakers. So Eileen and Grace's videos are ready to be published upon your approval. So they sent you the links. So you can take a look at them on your own time. And then if they're good, we can make them public. Sebin is scheduled to interview Megan. Suwon is scheduled to interview Sierra on the 21st, and she's still scheduling with Lauren. And then the manuscript has just begun. And we'll keep updating you on that.
Okay. So make sure they do one per each month. I know there's been delay in scheduling, but you know, what about Timothy?
Yeah, so he just joined. So we're going to get him. We're going to match him with someone to interview as well.
Okay. Who
So-
are the candidates? Let's just decide for Timothy.
Okay.
I think they are talking about the pacemaker project for you.
Do you guys have the candidates that we discussed? I don't recall who.
Oh, for team,
You can do William Pei.
Hyundai, okay.
Or Chin Young.
And then
Also, Lisa might be eligible.
Yeah. So let them choose language they like. If they want to interview in Korean, then you do English subtitle. If they want to interview in English, then you can put Korean subtitle. I don't know. Richards can do Chinese subtitle.
Oh,
You
I'm not
wanna make it- or do Spanish subtitle, whatever. Okay, I think William Chin Young is good. I said Lauren's good. Lauren Beer. Whoever who's in Chicago that let's see. Sarah. Yeah, I think we can do each one, William or Jinyoung or Iso, whoever one is available. I would say, yeah. Oh, you know what? Sarah would be good. Sarah Fenton would be good. You know, my neighbor.
Yeah, we can definitely reach out to her.
Yeah, you guys see her every day. So you say, you, I'm doing this, and you can send her my pacemaker Chicago Tribune article. Like, this is kind of spirit, and we're trying to interview oncology providers and give her like a sample clip. I think she'll be more than happy to do it. Yeah, Sarah Fenton, Fenton. And Liam, you can email her. You can find her email, search directory, or you can run into each other. She's very down to earth. She's very nice. So, oh yeah, Pedro, it would be good. Pedro Viveros. Yeah, he used to be our lab member. So, yeah, he can share a story about a young sarcoma patient. Anything that that is related to whatever we're trying to enhance, like patient-doctor relationship or any warm stories or anything. So yeah, Pedro would be good. So yeah, you know what? Let's start with Sarah and Pedro first before we get to William, Jinyoung, and Iser. I think they'll have, they're both attendings, so they'll have interesting stories. Yeah, I think I like to start with them. Yeah, let's do it. So keep assigning, okay, once a month. And work on, I don't know, the Instagram, because we were gonna do the pictures and quotes for the Instagram for each video. So whoever did the video, make sure they take good photos of the patient, and from the interview get some quotes so that the Instagram can be kind of like a one package. And ideally, like, can't rely on Shana all the time. So the one package is, subtitle and the thumbnail and everything. Just put that all in the SOP, and that team, it's like 2-person team, pair up and just finish that. And Shana can still help in the meantime, but I think going forward, she's going to probably go to dental school and be busy. So yeah, so work on that SOP. Yeah, okay. Okay, so I also am going to let's see, pacemakers. Okay. Oh yeah. So now I remember. So the in the web page, the admin has to be the only ones who are actively doing. So so Liam, make sure work with Eileen to move people who are not like doing the admin work. It has to be the real time like admin, actual people who are working on these projects. Or you know what? I feel like we could all like, so the team member, I think we should so the manager or the admin team has to be someone like the Liam and Eugene, you guys are like kind of managing the whole thing. And then you have like the YouTube team or the media team. I think making the videos, Instagram media team, I think it's better to structure that way, like the admin, media team, and then people who contribute stories. Could be, you know, story or writers. Um, so let's think about it. I just want to credit people for what they do. So media team, write, you know, writers of the story. And I want that to be more like a regular thing.
I agree. Yeah, that sounds more systematic and
Yeah. And if you're not doing it, I mean, like medical students, we can, I mean, as long as they do one per semester, or you know, one, you know, two per year, I mean, they can remain as a team member, so things like that. So but full-time researcher, it's once a month. But if they're busy with the school, maybe one per vacation, like whatever time they have. I think we can make an SOP that, you know, and writing stories, like Sierra, you know, is contributing a story to us. So and the writer, and then you can put like helper, or like helping with the you know, smaller things like making thumbnails, making subtitles. You know, you're willing to help make, you know, I don't know, let's just come up with something, a structure, and it's still admin, but media team. But think about it, brainstorm, and then let's recategorize people, because I know there are people who are not doing anything. So we can tell them, you know, you know, please contribute, either make, you know, interview someone, or you send us your essay, or you know, be active in managing. Just tell them, you know, so that people who are not, it will, I mean, I guess we will invite them to do something, but if they are too busy to do anything for us, then I don't think they should be on our website. I feel like it has to be revised. So think about it, Liam and Eugene. And you can discuss it with Ether too, because she's kind of one of the founding members. And brainstorm and let me know what you guys want to suggest. Let's work on that. I just want this to be over, like more like, yeah, let's make sure it's, and I can, this is like, you know, Illinois and registered NGO. We're gonna make this very formal effort, and we're gonna honor your volunteer time, whatever it is, you know, and this for whatever you do, medical school, residency, fellowship, applying for faculty. I think this experience of devoting your time for the cause of enhancing doctor-patient relationship, I think will only help you. But we don't want to give credit to people who didn't do anything. So that's Okay, anything else?
I think if you have time, I just want to ask just one case regarding collecting the data for hyperprogression, because sometimes we encounter some difficult cases. But I don't think everyone should be here to listen to that. So
What case?
for the hyperprogression they team and I are working on that, gathering all the pertinent information. And I will just share my screen to ask just a few questions.
Sure,
regard-
sure, sure.
Yes. Hmm. So for this case, so what we're collecting right now is the line of regimen.
Mhm.
For this, Dr. Shi, would you consider palliative more important than the exact number of regimens? So when we noticed the immunotherapy was used as a palliative purpose, then and it was tried, the patient received it as second line, then would you put second line or palliative for that patient?
So for any advanced stage, so unresectable stage 3 and stage 4 metastatic cancer, the purpose of treatment is always palliative.
Oh, okay.
So palliative is all inclusive. 1, 2, 3 can be all palliative.
Right. Then should we classify palliative or non-palliative other than the exact, beside the regimen, like line of regimen?
So I don't think you need number 4.
Okay, so I don't need only sort out first or second or third line. Okay, it sounds fair. And yeah, and then so for example, for this patient, if you see the treatment plan, bless you. So she, I think, yeah, she received 2 different immunotherapy. First was given in 2019 with other chemo, like atezolizumab was given to her around this time, December 2019. So I would consider this as her first, I would collect information around this time. And I think it's her first regimen, because other than that, previously all the treatment was not started.
Oh yeah.
Yeah, so I would consider it as a first line. And then she got progressed on this regimen, and she received ramucirumab and docetaxel as her as her second line. And for study M16438 ABB,
That's not immunotherapy.
That's not immunotherapy. So I can call it as a third line, but suddenly she progressed a lot again. And as her fourth line, she received pembrolizumab with other chemo. So for her, we have to collect the information about the atezolizumab and then the information about pembrolizumab regimen separately, right? In terms of hyperprogression.
So, your question is, should we treat this as a different case?
Right. And I think you said yes when I asked this question.
Yeah, I did.
Yeah, and then my question, I don't think it may be important but I want to ask you, how would you call this pembrolizumab in terms of cycle, like a regimen, like number
So it was given in combination to cycle.
combination, yeah.
So-
Pembro paclitaxel.
Right, so it's important to know whether it was given as a combination or
Mhm.
monotherapy, right? So
Right,
you're
right,
collecting that. So this is combination
right.
and patient progressed right through, just 2
Right.
cycles and progressed right through.
Right. So I
Ah.
would put IO plus chemo for this patient for this regimen.
Yeah, and the number of the line is you can
Uh-huh.
put number 3 as a third line or above, or a third
Right.
or more lines of therapy. So you can put that as number
Okay.
3.
Do we not need to? Do we not need to record any of the whether it's palliative or not,
I think so.
You
or should
don't
we?
need to record it. No.
Okay, got it.
Okay, any other questions? Cause I gotta leave.
Oh, yeah, I think we're good. Thank you.
Oh, okay. So, I'm gonna be in the lab likely tomorrow, so, yeah, still, come and ask me questions, tomorrow.
Okay.
Okay, I will see you guys.
Bye-bye. Have a good one.
Bye-bye.
Stop recording.